Okay, here we go. And thank you all for being here. My name is Gloria Bobby, and I am an anthropologist at the State University of New York here at Plattsburgh, where I've taught for 25 years. My main area of research and teaching is global issues, in which medicalization of healthcare is a topic addressed in my research and teaching of that class. Okay. Okay, I'm going to tell you a little bit about how and why the conference and colloquy that we're going to be doing later came about. In the late 1990s and early 2000s, there was a plethora of research done challenging the harm being done by medicalization of pregnancy and birth. Changes began to lessen that practice. Then abortion became a hot topic of politicians, and medicalization of pregnancy and birth sort of slid into the background. Last year, I stumbled across a documentary out of Australia, Birth Time, for which you all have a coupon for a discount to see it, and thought it would have been a great documentary when I was talking about medicalization in class. But why now? Why was this documentary coming out now? So, being a curious academic, I headed for the library databases, and I was horrified at what I found. Medicalization, under the cover of the abortion debate, has grown almost exponentially. It is such a problem that the World Health Organization and United Nations are attempting to address the issue to save lives which are being lost. I'm going to share some of what I learned from my trip to the databases to explore the research. After I explored this research, I discovered many international movements, and that is what we are bringing to you today, speakers from many of those movements. First, a disclaimer. Let's be very clear that there are times when medical intervention is critical. When medically necessary, these interventions, including C-sections, can prevent death and serious complications in mothers and babies. This presentation and conference is about the use of medical interventions when not medically necessary. The World Health Organization has determined that the ideal rate of C-section is 10 to 15%. And their research says that rates above 10% show no evidence of decreased mortality rates. And in fact, mortality rates actually increase as the interventions increase. Interventions disturb the normal physiology of labor and birth and restrict a woman's ability to cope with labor. Routine use of such things like intravenous fluids, restrictions on eating and drinking, continuous electronic fetal monitoring, epidurals, and augmentations of labor characterize most US births and many around the world. The use of episiotomy is also far from restrictive. Rather than decrease problems, these interventions often increase complications and risk of harm for mothers and babies. Let's look at some of these. First, let's look at the restrictions on eating and drinking and IV fluids. In 1946, Dr. Curtis Mendelson published an article about restricting food and fluids during delivery because it would prevent aspiration during general anesthesia. This became ingrained in the medical literature. And while it might be valid for a few at-risk births, there's no evidence that it should ever be done for low-risk births. It's almost never a case where you have general anesthesia during childbirth. Epidurals have taken that place, yet this is still in the literature and still is being done. Unlike in hospitals, when you look at birth centers or home births in many European countries, oral intake is actually encouraged to enhance comfort and nourishment during labor. All of these areas have lower mortality rates than do hospitals. Current research of women in labor suggests that oral intake should not be restricted in women at low risk of complications unless there's a possibility of harm. I mean, if you have a woman with diabetes, you're not going to hand them sugar. But as a rule, most women should be allowed to eat or drink during labor. Another one is the electronic fetal heart monitoring. This came about in the 1970s, and it was never based on any valid medical research, yet it became a standard of practice. Trials and research since then have found absolutely no difference in the outcomes for women having electronic fetal heart monitoring versus intermittent auscultation, which is the Doppler ultrasound sound, which used by doctors and nurses to listen to heart rates. It has actually been found to increase the occurrence of C-sections or instrumental vaginal birth. It disrupts the normal physiology of labor by restricting movement and potentially interfering with appropriate labor support, because providers and families tend to watch that monitor instead of doing what the woman needs. It certainly limits women's access to comfort measures such as showers or tubs or birth balls that naturally control pain. And it can ultimately increase the chance that we'll need an epidural and a further cascade of interventions. And those cascading interventions often lead to C-sections. One of the things we often hear about is women will say, well, I was in labor too long, or my doctor induced or gave me Pitocin because my labor was going on too long. That is sort of an oxymoron, because labor is not meant to be short. Labor has multiple stages and usually goes from 12 to 21 hours, and that's perfectly normal. There are 3 stages of labor, and the first stage has different transition phases that a woman goes through. The second stage is when the baby is about to be born. And the third stage is the expulsion of the placenta. These are not meant to take a short amount of time. So when someone says, it's been 8 hours, you need to be induced, or you need something to make labor go faster, it's not true. Okay, these inductions or Pitocin actually interfere with natural labor. They are rarely necessary. Labor is a long process, and natural labor is important to the health of the mother and the baby. These medications disrupt the natural hormone process of labor that readies the baby for birth. They also increase pain, often to levels that are intolerable, and then lead to the use of drugs like epidurals. These interfere with release of natural endorphins. The unnatural strength of the contractions caused by Pitocin and other drugs are difficult for mothers to manage and also put additional stress on the uterine muscles. Then we get into the use of epidurals. Epidurals then slow the progress, which then leads to more Pitocin being given, which then leads to more pain and more epidural. And this cycle eventually results in the need for a C-section. So let's talk about C-sections. C-sections are the most common major surgery, and I underline major surgery, performed on human beings anywhere in the world, and the most common in the US. They have become 500% more common over the last generation of moms. C-sections should only be performed when medically necessary, with an acceptable rate of 10 to 15%, according to the World Health Organization. As we see nations develop throughout the world, the rates increase because they tend to adopt Western ideas. These are some of the rates it would have. And if you look at the Americas, the average is almost 40%. C-sections increase the risk of harm to both the mother and the baby. Mothers can develop infections of the incision or of the uterus. They can hemorrhage, have heavy blood loss, develop blood clots. They can injure the mother or baby just by cutting. There can be problems from the anesthesia, and they also result in longer hospital stays in vaginal births. They create risks for future pregnancies. A woman who's had a C-section has a small risk of a scar tearing open during labor if she has a future vaginal birth. She also has a slightly higher risk of a problem with the placenta in future births, such as placenta previa. Babies born by C-sections are at risk for complications that are less likely to occur than with a normal birth. Many are born early, which can cause problems for the baby at birth and later in life. That date is an arbitrary date. We say your due date. Nobody knows when conception actually occurred, and that due date that people so religiously talk about is very arbitrary. There is a margin of error in determining fetal maturity. This may lead to premature birth, putting babies at a higher risk of death or illness. Babies born through C-sections may have breathing problems, especially if delivered before the natural due date. If the mother did not labor, babies are more likely to have difficulty breathing on their own. With scheduled C-sections, babies are more likely to be born prematurely before the lungs have fully developed. Respiratory complications can be serious enough to require admission to special care nurseries, NICUs. During labor, with each contraction, less oxygenated blood crosses the placenta, the baby's heart rate slows. The baby then produces catecholamines that prepare the baby to breathe on its own at birth. Other breathing issues can develop that may be life-threatening. Guess you don't want to see that I need to walk. Babies can be injured from the surgery. Vaginal birth colonizes the baby's gut. with natural bacteria from the mother's birth canal that helps to create a healthier system. You've all heard about a baby's being born immune to certain things because of the mother. That takes place during natural birth. More than doubles the risk of asthma as the babies grow older. Babies are more likely to have a certain kind of bacteria in their intestines if they are born by C-section. Babies with that bacteria have a greater risk of developing allergies or asthma later on. C-section also makes breastfeeding more difficult. Babies are less likely to have skin-to-skin contact immediately after birth. Pain medications can affect the baby's ability to latch on and breastfeed. The APA encourages all maternity care providers to collaborate to support breastfeeding by avoiding common, often unnecessary procedures that can interfere with breastfeeding and may traumatize newborns. Some of these routine procedures, such as suctioning the baby's mouth, esophagus, and airways, are not always necessary and can make it more difficult for babies to begin and continue breastfeeding. As the rate of cesarean section has increased in the US, maternal mortality has also increased. The US has the highest rate of maternal mortality of all developed nations. Many attribute the increase in mortality to the increase in unnecessary medical interventions. Pregnancy and birth for low-risk women guided by a midwife have much lower rates of C-sections. So why does this happen, and what are some of the solutions? Displacement of independent midwives and doulas in the maternal healthcare system and the move to hospital births, convenience and scheduling, patient request, and profit, which to me is the most egregious, are some of the reasons that these things are occurring. What is a midwife? We're going to hear a lot about midwives, and you're going to hear from some in other presentations. A midwife is a highly trained medical professional who supports and leads a woman and her family through continuous individualized guidance and care during pregnancy, birth, and the postpartum period. A doula is a trained professional who gives continuous physical, emotional, and information support to women and the family during pregnancy, birth, and the postpartum period. It's very unlike the traditional situation where you go to your obstetrician's office, you may see them for 10 minutes once a month until the baby is born. After the baby is born, you don't see them for 6 weeks, even though you may have questions, you may need additional support. That doesn't happen when you're working with midwives who are trained to function on their own. They are there continually to support not only the woman, but their family. Through the education that they give their patients, they eliminate the fear of birth and help women understand their bodies and the process, which allows a woman to handle natural birth quite well. They create the understanding that birth is a natural process, not an affliction that needs to be treated, and women are empowered to control their pregnancies and births. So let's talk about the displacement of independent midwives and doulas. To improve the maternal health care in the US and worldwide, we need to increase the number of midwives and doulas. Both the World Health Organization and United Nations, as well as other organizations, are working to do this. In countries like England, Sweden, Norway, New Zealand, where midwives deliver higher numbers of babies, they have a much lower maternal infant mortality rate than does the US. We need to empower midwives by respecting them as the professionals they are. In states where they have restrictive laws governing midwifery, there are poor indicators of mother and baby well-being. Midwives are not the usual thing that you see in TV shows. They are not the neighbor next door who's had a lot of kids of her own, so she knows how to deliver babies. These are medical professionals. We need to also encourage birth in birth centers, near to but separate from hospitals, under the guidance of midwives. In some areas that are very remote, this may not be able to happen, but still a birth center in a rural area is a very good system to have. The maternal health care system is one of the only major fields in which patients go directly to a specialist. Midwives need to be treated as the equivalent of the general practitioner in the maternal health care system. Countries which use midwives really have lower maternal health mortality rates than we do. And that I can't emphasize enough. Midwives are helping to save lives. In other areas, you have a general practitioner or family doctor who treats you first. They determine if you need to see a specialist. You don't go directly to an orthopedist or a neurologist. You see your family doctor and they determine if it's something they can treat or if you need to see a specialist. This should be the role of the midwife. Midwife should be the primary care person who then determines whether you are an at-risk person who needs to see an obstetrician or whether you can deliver naturally. One of the things that I've seen recently is that there's indication that the very culture of hospitals affect the rate of C-sections. Hospitals are where people who are sick or injured go to be treated or healed. Doctors in hospitals often feel the need to heal or treat the person, and they often believe they have to do something. And this occurs in all hospitals from what I've discovered. So let's look at a couple in Massachusetts. Cambridge Hospital, which is part of the Harvard Medical School teaching hospitals in the Cambridge Health Alliance, has moved a unit out of the hospital. They are now in a Victorian house that's across from the hospital. Obstetricians are affiliated, but it's primarily operated by midwives unless there's a high-risk person. They have emergency equipment, but it's hidden out of sight so as not to create the idea that this is a medical thing, we've got to treat you. It gives the impression that natural birth is what is normal and helps the woman through that process. It also affects births in the main hospital because doctors become used to working in a different cultural environment. OB is assigned 24 hours for emergencies, but midwives and doulas are the primary caregivers in this situation. Midwives perform over half of all deliveries at the center in the main hospital. This hospital was named the best maternity hospital of 2021. So why would people choose that? It's very comfortable. Their rooms give them everything they need. They have jacuzzis, they have family rooms. If you look at the pictures, it looks like being in a home. It's comforting, it's warm, and it's inviting. They have a garden where a woman in labor can walk. They have a playground for the family of the woman, can take the children out to play while she's in labor. And all prenatal care is there. During labor, the woman has freedom to move about the home. She is not in a bed laying on her back, waiting for birth. She is in a position where she can move around. She can go to the kitchen. She can fix a cup of tea. She can do whatever she wants, including walking through the garden. It gives them access to the midwife who has been there with them. This midwife is someone who will understand their personal needs because this midwife knows the person much better than a doctor will ever know them. They are there all the time with them. They have a midwife and doula who has talked to them and educated them about what's going to happen and made them feel comfortable and put the woman at the center of the childbirth experience. Families are welcome. The midwife will include the family as much as the mother wants. This birthing center is fully accredited and has been deemed a baby-friendly facility based on World Health Organization and United Nations guidelines. They have reduced their cesarean rate to 15%. This is the birthing center that we're talking about. That's a home. That is not a hospital. It's very inviting. So let's look at another hospital that's in the same alliance. This is another university hospital, and they often deliver babies and women who are at higher risk because they have the NICU unit. But even when discounting the high-risk deliveries, low-risk women are still 3 times more likely to have a C-section. This is most likely because the culture of the hospital says women have to be treated. It's something that has to be treated. They do not use midwives. And it's important, again, to point out the maternal health care segment is the only segment of healthcare that has an increasing mortality rate. Heart problems are going down, cancer is being treated well, decreasing mortality rates, but not in maternal health care. Midwives with the assistance from doulas need to be able to operate independent birthing centers that are remote from hospitals. Hospitals are not the place to give birth. A doctor who wishes to remain anonymous out of fear of retribution actually said to me, the most dangerous way to birth a baby is in a hospital with an obstetrician. And that's, again, I want to point out, as I said at the beginning, These healthcare things that happen are valuable to save lives, but we need to remember that it's not a we, they thing. Doctors are under pressure to perform cesareans. Midwives need to be professionally trained, as do doulas, and the birthing center has to be inspected and approved, just as the one I just showed you has been. Okay, so let's look at some of the other reasons. Convenience, scheduling, or patient requests. 3 common reasons, other than profit, that hospitals and doctors are encouraged to do non-medical C-sections. Convenience. This allows easy scheduling of rooms and personnel, eliminates nighttime, weekend deliveries, shortens time of labor and delivery to manageable units of time, which means easier scheduling for delivery rooms or whatever. Sometimes there's a lack of supervision or training. Some medical schools are training students to treat pregnancy and birth as medical issues that require intervention. And there may be an absent or lack of observance of clinical guidelines that ignore the best practices or research data about pregnancy and birth. So why would any mother request a C-section when most mothers would do everything possible to protect their unborn child? Convenience, or the ability to select a date to schedule work or other duties. Fear of childbirth, which is almost always due to a lack of education about how the body works. Encouragement from a doctor, or lack of informed consent or valid information about possible harm to the child. This tends to be rather hypocritical in the medical field, because if a woman decides to take drugs during pregnancy and the baby suffers harm, it's considered illegal and she can be prosecuted because by law, she is responsible for the unborn child. But if a woman decides to have an elective C-section and the woman suffers from birth at the encouragement of a doctor, it's acceptable because the medical community is benefiting by scheduling her profit. This is a big one, and we have an attorney who is going to address this issue later in the day. Lack of informed consent. I have been on an IRB board for 2 different universities, and IRB taught us all about possible harms have to be included in any informed consent document. Mothers have to be informed of any possible harm, not just to herself, but to the unborn child. As I reviewed some of the online informed consent forms for C-sections, some show a minimal risk to mothers is included, but I didn't find any that talk about risk or possible harm to the babies. There may be some, I'm not saying that no one does it, but those that I found when I did a search did not address possible harm to babies. This violates informed consent, which is a law. That is not an option, it is a law. Where information is given, it usually emphasizes that all risk is minimal, which tends to encourage the procedure. And here's another one. When it's informed consent is asked for, it's usually done during labor or delivery rather than earlier in the pregnancy to allow mothers time to make informed decisions. Mother in labor is not in any shape to give informed consent, nor is the father, because when you walk in during that time when she's in labor asking for informed consent to a C-section, the assumption that something is wrong almost always occurs. Mothers who receive full information about possible harm to not just them, but to their babies are much less likely to agree to a non-medical C-section. Hospitals often introduce pressure that may alter the birth choices. Labor rooms are scarce, and patients and doctors may be subject to implicit or explicit pressure to avoid taking too long. Remember, it said doctors are under pressure as well. So we don't want to say all doctors are doing these things for the wrong reason. Most doctors want to do the right thing by their patients. Sometimes C-sections around morning, lunchtime, or the end of the day are based on induced or interpreted as demand by doctors who need to respond to scheduling pressures like getting to office hours, eating lunch, going home. There are a few who will do that. I need to be home for something, so we'll do a C-section rather than waiting for natural labor to finish. Some physicians are routinely paid more for C-sections than they are for vaginal deliveries, usually about 15% more, and hospitals also benefit financially. Indeed, studies have shown that the more physicians are paid for C-sections relative to vaginal births, the higher the C-section rates become. When these differentials are reduced, C-section rates decrease. So there's a recommendation by the researchers that we need to change the monetary incentives. How much money are we talking, and how do we bring about change to the maternal health care system? In 2013, a research project determined that the C-sections that were being done would save in 1 year about $5 billion. In today's money, that would be over $6 billion. We need to remember when we talk about insurance rates or we talk about Medicaid, which is based on taxpayers paying, this is where those rates come from. This is why they are high. If we're paying for non-medical procedures to be done, $6 billion a year, just think what that amount could do if it redirected to people who needed necessary care, or if it could reduce the cost of insurance or taxes. So how many are we doing in the US? Even though we know that C-sections cause problems like bleeding, fetal distress, and other things, they are associated with complications that are very risky. The surgery is also associated with adult obesity, diabetes, and respiratory infections, and delayed microbiota development for babies. Yet they continue to be done for non-medical reasons. Per the CDC rates of today, birth rates, C-section births range from 22.9% in Alaska to 38.2% in Mississippi. In New York State, where I am, the average is 33.6% in 2022. Not much has changed since 2014 when the study was first done, and we are the 12th highest in the nation for C-sections. So what are some of the things that I found in the literature about how do we stop this? How do we solve this solution? Some suggest that we should require pre-approval by insurance for C-sections, just as was required for other expensive treatments or tests such as MRIs, CTs, or other. If you have a broken leg, or if you go in for a test and your doctor wants a C-section, or I'm sorry, a CT scan or an MRI, they have to get that approved by the company before they will pay for it. If it's not medically required, insurance should not have to pay. And that is one of the recommendations found in the literature. These need to be approved in advance if it's for non-medical reason. Another suggestion was to change the payment schedule so that the price paid is the same for vaginal or C-section birth in cases where insurance decides to continue paying for electives. And another one that I found was that enforce laws that require fully informed consent, so mothers understand that selecting a C-section could harm the baby. A few lawsuits where informed consent is not given for an elective procedure when harm comes to the baby would certainly discourage the practice in the future. Okay, this is just a final thought that occurred to me. And actually, this was brought up to me by a student when I talked about this in class. The student and I both thought about this. He said a woman cannot profit from her body. If a woman uses her body even to make money to feed her hungry children, it's considered unethical, criminal prostitution, and she's punished and her children are taken away. And as the student said, why then can hospitals and doctors profit from a woman's body? Why is it considered ethical for hospitals or doctors to perform unnecessary procedures on a woman's body for profit that could lead to harm to her or her baby? How can society deem this to be ethical? Now, this is basically information that I learned from the academic databases and the research that's stored there. In addition to sources that I cited on the reference slide, a bibliography is provided, and the next 43 slides are links to data supporting what has been presented. I would welcome you to email me if you'd like a copy of this, which contains these links, which look like this. And as I said, there are over 43 pages of these where you can look for yourself and read about it yourself. Okay. Okay, so here we are, we're back. And as I said, I've shared this research with you because this is from our academic, this is actual valid scientific research, which you can read for yourself and search for this in any library database will bring it up. And I thank you all for coming. I don't see any questions, but if there are any, please feel free. Oh, thank you, Colleen. I'm just happy to have all of you here, and I hope you're all enjoying all of the amazing presentations that are going on today. We were able to bring together people from the World Health Organization, United Nations, and other organizations that are working around the whole world to talk to us about these conditions here and in their countries, where it has become a global crisis. Was countries have developed in countries like Bangladesh, where doctors have left the countryside to go to hospitals because women are being told they can only give birth safely in a hospital. Women are left with no health care, and they're dying because of that. So it's a global healthcare crisis. Okay, no other questions? Then I thank you for all for attending, and I hope you will continue to view the rest of the presentations that are going on today. Have a lovely afternoon or morning, depending on where you are.